All right, welcome back to another episode of the Exploring Health and Medicine podcast, where today I will be talking with Professor Per Hall at the Karolinska Institute at the Department of Medical Epidemiology and Biostatistics, and he's also a senior physician at Södersjukhuset in Stockholm. Much of his research has been focused on prevention and early detection of breast cancer. Now, breast cancer is a very common form of cancer, unfortunately, and I believe firmly that prevention of diseases in general can have a very large positive impact on human health. And since breast cancer is a very common form of cancer, I believe that learning about prevention of breast cancer is of great interest to me, and hopefully it can be a learning experience, this conversation with Per Hall, for you too. All right, welcome Per Hall to the Exploring Health and Medicine podcast.
Thank you very much.
So today we're talking about breast cancer prevention, but first, could you give a brief overview of how common breast cancer is in Sweden in particular and throughout the world as well?
Yeah, so it's unfortunately, very common disease. I started talking about an epidemic earlier than the COVID. So in lecturing, I talk about the breast cancer epidemic. So in Sweden, there's approximately 80,000 women a year, corresponding to 1 woman in 8 that will be diagnosed with breast cancer, also corresponding to approximately 1 woman an hour diagnosed with breast cancer. The equivalent figure in Europe is 1 woman diagnosed with breast cancer a minute. So it's a very, very common disease.
Yes.
And it looks the same all over the Western world. It's less common in the developing countries, even though it's catching on due to the fact that more and more women are moving into what you could call middle class, and middle class women do not give birth to children as early as in developing countries. And a good way of protecting yourself from being diagnosed with breast cancer is to have many children and start very early in life.
How does the incidence of breast cancer vary between the sexes, so females versus males, and also how does it vary throughout the lifespan, so at different ages?
Yeah, so we start off with the sexes. So approximately 1% of all breast cancers in Sweden and throughout the world are diagnosed in males. This is a very, very common disease, and it's also, even though it's an uncommon disease in males, it's cumbersome because males, the few male patients I have attended over the years, they have not only to deal with the breast cancer, also to deal with the psychological effects of having breast cancer and attending a part of the Department of Oncology that's normally only visited by females. So it is a problem. And furthermore, male breast cancer is quite aggressive compared to most female breast cancers, probably because we don't screen for breast. That's one of the reasons we don't screen for breast cancer in males. Then you asked about over age. So it's very, very uncommon to see breast cancer below the age of 30. Slightly, it's a slow increase. And you could say that it's uncommon to have women with breast cancer be diagnosed with breast cancer before the age of 40 who do not have a quite profound family history of breast cancer, ovarian cancer, and a lot of other cancers. So the younger women are, the more genetic, the more family history is involved in genetics, and the older, you could say pure chance or unluck. And that's how you could phrase it in a very simple way.
Yeah. So you mentioned that male breast cancers are in general more aggressive, and that it is probably that way because they are detected later in their progression, like at a later stage of progression. So can you explain a bit how the screening system in Sweden in particular works for women and the detection of breast cancers in women?
Yeah. So the screening program in Sweden started very early, started more than 40 years ago. And the first studies that showed that screened women have a better prognosis due to the fact that the cancers are detected earlier, they were published in the late 70s. So the mammography screening program in Sweden started in the early 80s, and then by early 90s it was implemented throughout the country. So we have a quite generous system in that, or program in that we invite women from the age of 40 to 74, and they have a mammogram every second year. In most countries in Europe, the invitation reaches women who are between the age of 50 and 69. And in most countries, they do every second year. Great Britain is one of the alternatives where they screen every third year. In the US, they have several different kinds of programs. Several authorities are giving different guidelines. So, but I would say that approximately half of the females that are screened in the US, they are screened every second year, and half of them approximately every year, which is quite often. So that's how it looks.
Yes. So it sounds like, and I know from doing some research before this podcast recording, that age is the only factor taken into consideration in regards to selection of who to screen when.
Exactly. So we have all current screening programs in the world, that's correct. They are age-based screening programs. Yes.
Yes, but you want to change this, right?
So to change this, because I'm convinced, or many others are convinced, that not all women have exactly the same risk of breast cancer. That's one thing. Not all women have the same possibility. It's not as easy in all women to identify a cancer. So what we're going to get into, I assume, is what we call the mammographic breast density. So what we want to do, what we were launching a study next year, where we want to test whether risk-based screening is more efficient than age-based screening. And with risk-based screening, we would like to identify the high-risk women and those who have breasts that are difficult to examine, and invite them for additional screens, supplemental screening, that's called. That's what we want to do.
Mm-hmm, mm-hmm. So is this more of a gradual change in the screening system, or is it like an entire restructuring of how screening is done?
It's a very, very good question. So up until 10, 15 years ago, risk-based screening was not discussed at all. People were happy. We're not talking, we stick to Sweden, otherwise it's going to get too long. But in Sweden and most other countries in the world, it's been age-based screening. Even though radiologists and nurses, they have long known that some of the women with very dense breasts, they know that they have a high risk of breast cancer. They know that it's very, very difficult to identify a cancer. The 10% of women with the most dense breasts, the sensitivity in these women, that is the ability to spot a cancer, is 50%, which indicates that every second cancer is missed. So it's frustrating for radiologists to send these women home and say, you haven't got cancer, because that's not really correct. They should tell the women that I could diagnose a cancer, but it doesn't necessarily mean that you didn't have a cancer. But the rules and regulations by Södersjukhuset, or National Board of Health and Welfare, is that you should invite women between the age of 40 and 74 and offer them a mammogram every second year. But the concept of this has now slowly changed. As I said, 10, 15 years ago, people didn't discuss it. Today, it is discussed, and there's a slight frustration among the radiologists, the doctors that take care of this. They want to change it. So I think that it's time. The thinking, the way of thinking that maybe it's time to take a next step has slowly changed the mindset of very many people.
Sure. So which other factors than age would be the first ones to be integrated into a new screening system?
That's also a very good question. So there are a couple of risk models called risk models, and some have been around for 30, 40 years, and they were based on family history. Do you have a sister who has breast cancer? Do you have a mother and aunt? They were based on previous benign breast disorders. They were based on number of kids, breastfeeding, oral contraceptives, and so forth. These risk models are fairly good to estimate the lifetime risk. But if you want to change screening, the lifetime risk is probably not the best thing. So what we started a couple of years ago is, let's say 10, 12 years ago, we asked ourselves, because it works like this. So if you have 1,000 women who are screened, 30, that's 3%, will be recalled, and 5 out of 1,000 will be diagnosed with breast cancer. But there are 970 who are sent home with a negative mammogram, and we know that 5-10 of them will come back within 2 years with what we call an interval cancer. That's a cancer diagnosed between 2 screening intervals, or an interval between 2 screens. So we asked ourselves, what are the factors that influence the risk of being diagnosed with interval cancer? That's a very short-term risk model. So we were convinced it had something to do with genetics, and we have been a part of big genetic consortia. I even headed that for a while. We have identified nearly 300 variants that increase or influence the risk of breast cancer. But these variants, they influence the lifetime risk. So what turned out to be the key for a short-term risk model was the images, the mammograms. So we have something we call the karma cores, and the karma core consists of 70,000 women, where we are constantly collecting all the information you could think of. Among them, images, mammograms. We have 6-7 million mammograms. So what we did was that we asked the program. This is a form of AI, or artificial intelligence, called machine learning. So you have thousands and thousands of mammograms in women who will later develop breast cancer. Then you have thousands and thousands of mammograms in women who will stay healthy. Then you ask the machine or the program to identify structures that are different among those who will develop breast cancer and those who will stay healthy. And then you identify mammographic density, asymmetry between left and right breasts, microcalcifications, something called focal masses, which is the dense part of the density. A lot of structures that are very hard for us to understand what it is, but the algorithm tells us that this is something that increases the risk. So by using AI-derived image-based model and adding some few factors like family history, age, BMI, a couple of others, then we're now fairly good at identifying the women who will be diagnosed with breast cancer within 2 years.
Mm-hmm. Would you say that using a few genes like BRCA1 and 2, and just using like the, let's say, top 10 genes that have been found to have the largest impact, starting from there and integrating those genes into the models for the screening, or using a lot of genes that might have a small impact, but just starting to use big data on those and calculating polygenic risk scores? Like, should you do both of those or start with one? How do you think about that?
That's a good question. So firstly, women with the BRCA1 and BRCA2 and BAC1 and 2 and all these genes, the ATM, they should not, I'm not actually talking about them because they have a sky-high risk. if you're diagnosed with or if you carry a BRCA1 mutation, then you should be surveilled. You should be screened every year, and you should definitely not only use mammogram. You should use an MRI or ultrasound or whatever. Normally an MRI. So these women, they have such a high risk, so they are not part of this, and they should not be part of ordinary screening program. They should be treated separately. Then you asked about the single nucleotide polymorphisms, the fairly common variants with a very low risk, and it can fuse. So there's one model that fuses through 1313 of these SNPs. Again, we have incorporated them in our models, and it adds very, very little. It's so small. Again, David, in the short-term risk model.
Yeah.
If you have a longer risk model, which we are not interested in, it most certainly will have a bigger effect. But for a short-term risk model, you could actually just use the images, age and BMI. That's enough to get a really very good estimate of your risk.
Yeah. Okay, so age, BMI, and the mammogram images.
Yes.
Yeah, interesting.
It's also, if you think about it, it's very easy because women come for screen. The mammograms are taken, stored, so you could just run them through the algorithm, and in the mammograms there's something called DICOM headers, and these DICOM headers there you have the information. For instance, age, you can easily add BMI if you ask the woman, or if you do that in another way. So it's no blood sampling, no transportation of blood to laboratory, no analysis, no. So it could be that genetics could add a little bit, but it's still so little, and I think that the cost is actually not the cost of genotyping, because that's very, very cheap today. The cost is blood sampling, transportation. That's what it costs.
I see. I have a speculative question, which I suspect will be a speculation, a speculative answer from you. But do you think that there will someday be a marker, like a blood marker, biomarker for breast cancer, such as there is for example, prostate cancer with PSA?
That's a really good question. So we teamed up a couple of years ago, 8-9 years ago, with a very strong team from SciLife Lab and KTH at Royal Institute of Technology here in Stockholm, who did a lot of protein analysis. And we had our data set, again, the KARMA cohort. So they were doing trans analysis on proteins, hundreds and hundreds, if not thousands of them. And I was so convinced that we would find the equivalent of PSA, as we indicate. We actually phrase it like the MSA, the mammography antigen, but nothing really came out. And we have done so many the mammography specific antigen that would be absolutely amazing. But I don't know how many analysis, how much money they have spent using our samples, and there are a couple of papers out, but we haven't got anything. The reason, I think, is that most breast cancers diagnosed in screen populations are very tiny breast cancers. They are not even 20 millimeters. They have no dissemination to the lymph nodes. So I don't think they leak proteins. I don't think they leak DNA, tumor DNA. So I think it's luckily it's most of them are in early phase, and most breast cancer are also very slow growing. So one day it could be that we have a blood test, but I haven't seen anything yet.
I see.
And I just wonder if it's going to be that simple.
Yeah, I mean, one can hope, but there seems like there has already been quite a bit of research trying to find such markers. Yeah, I see. Can you elaborate a bit about the AI model that is the engine for the screening system that is the next development of the current one?
So I can't elaborate on the AI model. Then you have to ask Mikael Eriksson, who is the brain behind all this. So Mikael, that's what part of his thesis work. He worked for many, many years. And you see, so it sounds easy. You just analyze the images, and then you will get a risk score, and you could tell the woman. But this is far from it's. You see, each vendor of mammography machines, that's General Electric, it's Siemens, it's Fuji, it's Philips. They perform and their images in specific ways. So it's extremely difficult. You can't use one program. You have to have vendor-specific algorithms. So that's the first hurdle. So in the early days, Michael couldn't even, do a simple thing like measuring density. You couldn't use the same algorithm for Fuji and GE, for instance. It didn't work out. So that's the first challenge. But if you want to have an in-depth discussion about how the AI model works, you have to turn to Michael, who is now in Cambridge working on this model, by the way.
I see. But you have been involved in research on another up-and-coming method within the field of breast cancer prevention, to my understanding, which is the use of either tamoxifen or its degradation product Endoxifen as a preventative treatment for breast cancer.
Exactly. Maybe we should just stay with so
Sure.
I will definitely talk about prevention, but
yes,
also
please continue.
yes. So we are going to launch in January next year. That's a couple of months ahead. We will launch what we call the Stockholm Mammography Risk Trial, which in short would be SMART. So normally when we come up with names for our studies, we begin with the acronym, and then we think about what could this stand for. So we start with SMART, and then with Stockholm Mammography Risk Trial. So there we're going to use the algorithm. We're going to invite women at high risk. Most of these women also have dense breasts. So as we talked about already, there's no reason to just do another mammogram, because if they have dense breasts, we will still not find it. So what we will then do is a fairly novel. It's been around for quite some time, but when we started using contrast enhanced mammography 4 or 5 years ago at Södersjukhuset in Stockholm. We were the only ones. There was one unit in Västerås also used it, but they had done like 30. So what's done is that you inject ordinary iodine contrast, and then a cancer has a lot of blood vessels, and they are really bad quality. So they leak in the breast. This is a leakage of iodine out in the breast. So even in a very dense breast, you take two quick images. One with a low energy, which is looks like in an ordinary mammogram, one with very high energy, which then the image is more or less white. But then you could deduct the background enrichment, and then you have it's like a star. Some of these patients, you have a completely dense breast, you can't see anything. Do the injection of iodine, do the reduction of the background enhancement, then you see the cancer. So this is what we will offer women who are at high risk. And then since they have an increased risk of interval cancer, they will also be offered an extra mammogram after 12 months. So that's what we will do. But then, and we're aiming at doing in 2 years' time 6,000 contrast enhanced mammography examinations, which will be by far the biggest study. Hopefully we'll find more cancers at the screening, and that's good, of course. But at the same time, if you don't decrease the number of interval cancers, then there's something wrong. Interval cancers are supposed to be more aggressive, and so you have to find more cancers at the initial screen, and then as a consequence, the number of interval cancers should decrease. If they don't decrease, that could be an indication that you only find nice cancers, not particularly aggressive cancers at the screen. So it's very important to follow these women for 2 years. So that's what we do.
Nice.
Yeah.
Will this, do you think, be cost effective, considering that currently a mammography screening session for a woman going in to screen themselves is around 5 minutes or so for the patient when they are actually in the room? But I would assume like actually getting the needle ready and like getting injected with iodine contrast and so on would add a few minutes to that at least.
Yeah, so that's a really good question. Only good questions, David. I'm impressed. What's sometimes done with women who have dense breasts is that they are sent for an MRI, magnetic resonance imaging. An MRI takes approximately an hour if you also count the time it takes for the radiologist to go through the images. So an hour long, you can't have a procedure for screening. You can't screen 1/5 of the women if you assume that 1/5 of the women have a high risk. That doesn't work. And besides, an MRI machine is horribly expensive. We're talking many tens of millions of crowns. Contrast mammography, as you say, so a normal mammogram takes 6-7 minutes. A contrast mammogram is like 10-12 because needle and so forth, but it's quick. So if it takes around 10 minutes, then you could do 4 or 5 easily an hour. And furthermore, so that's one of the advantages. The other advantage with the contrast mammography is that it is cheap. So you could, most of the new mammography machines, you could upgrade them to the cost of 400,000 or 500,000 crowns. And then you could then use contrast mammography. Then you need an injector, that's another 100,000, but compared it to tens of millions, so it's virtually nothing. And it's also so that for the radiologists, they absolutely love contrast mammography because it's so quick. It's another 4 images, and they could just see. So now we're talking about detecting, but if you could also have, you could easily, it's easy to understand that if you have a very dense breast, difficult to examine, do contrast mammography, and it's absolutely blank. There's no uptake whatsoever. Then the radiologist could quickly say nothing. You could come back in 2 years' time.
Yes, and that would save a lot of time for the radiologist, and that's the type of resource as well that would be saved, right?
Exactly. So I think this will be cost effective given how cheap it is, and so I assume that.
Yeah, will be interesting to follow and see what the results of the study.
Yes.
You mentioned the breast density as a factor making it harder for the current mammography method and interpretation of that method as regards effectively distinguishing a breast cancer from a non-breast cancer X-ray. In my understanding, estrogen in general and high estrogen levels promotes the growth of the glandular and fibrous tissue of which breast dense tissue consists.
Yep.
Yeah. And so another method for and that's also right where breast cancers grow in this fibrous and glandular tissue, right?
Absolutely so.
Yes. So another method for improving the detectability of these of breast cancers, but also for the reduction of the risk of actually developing a breast cancer would be then tamoxifen or endoxifen treatment. Do you want to comment a bit on your work there?
Yeah, so you could say that the what we do in the group is that one leg is early detection, as we now talked about. Another one is prevention. And tamoxifen, as you mentioned, David, it's a drug that was developed in the 60s. Firstly, the purpose of it initially was to be an oral contraceptive. pillar. But it turned out that it was a really bad oral contraceptive. So then not really much happened, but in the late 70s, they realized, these were the ages when people realized that breast cancer is something where there was a link between breast cancer and estrogen. So since tamoxifen blocked the effect of estrogen, even though in those days they didn't really know it because they were not aware of that there was an estrogen receptor. Anyway, tamoxifen was provided to patients in order to reduce the risk of recurrence. It worked out fantastically well. So this was late 70s, early 80s. And quite quickly, some genius thought to himself or herself that if tamoxifen reduces the risk of recurrence, what happens if we give tamoxifen to perfectly healthy women? And the fascinating thing is that it reduces the risk of breast cancer in healthy women by 50%. So it's a super drug if you think about it. Just take a pill and the reduction of breast cancer is 50%. As we talked about, there are 8,000 women in Sweden who are diagnosed with breast cancer. So think about that, if that could be reduced to 4,000. Unfortunately, tamoxifen has horrendous side effects. So it's, there's menopausal-like side effects with sweatings and nightmares and decreased interest in sex and all the horrible things you could do, hot flashes, all these things that you could think about. So that could be acceptable for patients who want to reduce the risk of breast cancer, the recurrence of breast cancer, even though we have conducted studies where we show that patients, they're supposed to take the drug in 5 years, during 5 years, and last year not even half of the patients are actually picking up the prescription. So it's a tough therapy. So what we did was we tested lower doses of tamoxifen in perfectly healthy women. So the established dose is 20 milligrams. We tested 10, 5, 2.5, 1 milligram, compared it to placebo, and turned out that. And then we used as a proxy for therapy response, because in the sort of established way of doing these studies is to randomize women into placebo or active compound, and then you follow them for 5 years and see how many cancers they develop, and it's really a lot of women. But we wanted to test, this was a dose determination study, so instead of waiting for 5 years and counting the number of cancers, we followed what you indicated, namely mammographic density. So we know from before that women who respond to tamoxifen, they also have a decrease in the mammographic density, quite dramatic. So we were able to show, we published into 2021, we had to show that we could probably go down all the way to 2.5 or 5 milligrams, and we still have the same effect on the density as 20 milligrams. And the reduction of the really severe side effects was there. So it was good. But even though we digging into a little bit deeper into the results, it turned out that yes, there was a reduction in side effects, but they were still there. So then we started thinking, we teamed up with a little company in the US, Atossa Therapeutics they are called. So then the concept is that tamoxifen is more or less inactive. It's a so-called prodrug. Has to be metabolized in the liver, and tamoxifen is metabolized to 23 different metabolites, one of them being endoxifen. Endoxifen is the metabolite that has the strongest affinity to the estrogen receptor. It clings on, binds to the receptor in the strongest way, also has the highest concentration, plasma concentration. So then we started thinking, could that be an alternative under the hypothesis that endoxifen is behind the effect, while some of the other metabolites could be the one that causes these horrendous side effects? Because from a purely theoretical perspective, it could be that some of these metabolites look like they could cling, they could bind to the serotonin receptor, for instance. And it's also been so that endoxifen has been tested at a few sites to give to patients. And so when we started this study, we included the first patient in December 2021 and stopped recruitment this summer in May. Before we started, there were very few. There were a handful of individuals who had been exposed to endoxifen, but it looked like it's very promising because there were very few side effects. Now we have they are just so you will be one of the first that were revealed the results. So we included 240 women, 80 women on placebo, 80 women on 1 milligram of endoxifen, and 80 women on 2 milligrams of endoxifen. It turns out that there are virtually no differences. So firstly, I should start by saying that 1 and 2 milligrams of endoxifen lowers mammographic density to the same extent as 20 milligrams of tamoxifen. That's really promising. It looks like the effect is there. And when I got the result 2 or 3 weeks ago, I was super nervous because we didn't know about anything, what happened to the density. We knew that the women, the 240 women in each arm, very few of them complained about side effects. There were very few had night sweats or hot flashes and so forth. So that was promising. If you compare placebo to 1 milligram, there's no difference in side effects. And remember that 1 milligram seemed to, or lowers density to the same extent as the established 20 milligrams of tamoxifen. If you compare placebo to 2 milligrams of endoxifen, there are some symptoms like hot flashes, night sweats that are more common, significantly more common in 2 milligrams. But again, no difference between placebo and 1 milligram, which is extremely promising. So we will, as soon as we have the final results, as soon as we have been through applications to Läkemedelsverket, to the Medical Products Agency, that's Läkemedelsverket in Swedish, and to the IRB, that's Etikprövningsmyndigheten, we will hopefully launch a study, and that takes an enormous amount of time, so maybe in 1.5 years, 2 years maybe. So so the way I'm looking at it is that future screening programs will not only be about early detection, it's also be so for women who have increased risk and dense breasts, you will offer them contrast mammography or whatever you think is appropriate when it comes to examination procedures. But for those that are really very, very high risk, I don't think it's enough to offer them just early detection. They should then also be offered endoxifen. And if it turns out that our initial results holds, then I think it's really straightforward to prescribe a pill that reduces risk of breast cancer by 40-50%, and at the same time give very, very few side effects. And then sometimes when I talk about this, people get a little bit upset and say, but can you really do that? You ask people to take a pill just to reduce the risk. And then I tell them that that's what the cardiologists have been doing very cleverly over the last 40 years. There's nobody who questions statins, lower cholesterol, or whatever you use for lowering your blood pressure. And it's sort of accepted when it comes to cardiology, which is very good. So it's accepted that you actually don't treat a disease, you treat a risk factor. So my hunch or hope is that in the future we will treat women at high risk, and it could also be that it will be like a pill for blood pressure, where you could measure your blood pressure and say, oh, I got an effect, so I'm well motivated to continue. Maybe in the future we will measure density and see that yes, it decreases, so you're well motivated to continue. But I'm convinced again, though, that you will use early detection and prevention.
Right, yeah. But so is the vision to treat every healthy woman with endoxifen if the results are good, or is it that the ones that in the future screening program turn out to have a high risk are
Exactly
the ones who get the prescription?
Yeah, so there are scientists. I met one very many years ago in London. He talked about the polypill. The polypill would include everything you could think of, but I think no. So your question should be answered. Only those who benefit from it, of course. So you wouldn't treat someone with statins if they don't have a high cholesterol. So that's the answer to that question. Yes. Those who benefit.
Yes. So, do you have anything else that you want to mention as regards endoxifen or tamoxifen?
No. I talked to clinician a couple of hours ago discussing something else, but I revealed what I just told you about the promising results, and she was really excited because she thought that all clinicians, those surgeons and oncologists working in breast cancer, knows that tamoxifen is a super good drug, but it has the side effects, and so even oncologists who are prescribing it to patients are reluctant to always prescribe it. But if you could find something that's where you still have the effect, it's like a little bit like a dream coming true. So you have a compound where the effect stays there, but the side effects are dramatically reduced. So she was enthusiastic when I told her.
Yes, nice. So I'm thinking we will continue talking a bit about some risk factors that are under the control of the individual. So I'll mention a risk factor, and you can please comment, for example, on the strength of the evidence as regards that risk factor, and the strength of the size of the effects, so to speak, and also how the individual can take control of the risk factor in question. And
Yeah,
I'm thinking we can start with alcohol.
Yeah, so what we normally call modifiable risk factors, where the individual can do something about it. I think maybe we should start by talking a little about, because when I lecture about risk and risk models, people ask me, so what is the strongest risk factor? And then I said, then you have to back off and say that you have to think about either the individual or the population, because if it's on the individual level, there's no doubt about it that except for being a female and of older age. So of course, 72-year-old woman has a higher risk than a 7-year-old boy. That goes without saying. But if for an individual to be a BRCA1 or 2 carrier, that means that you more or less, it's not if you're going to be diagnosed with breast cancer, it's when you're going to be diagnosed with breast cancer. But on a population level, the influence of being a carrier is not profound because it's approximately 1 woman in 2,000. So on a population level, that really doesn't really affect the incidence of breast cancer. So it's only 1 or 2 or 3% of all breast cancers actually that's also diagnosing carriers. So that's on the individual level. So on the population level, you have other factors, and these are, because they're, as you indicated, they're more prevalent. So if you have your first child very early in life and you have many children, and if you breastfeed, then you dramatically lower your risk. The population dramatically lowers the risk of breast cancer. So one of the reasons why breast cancer incidence is going like this over a calendar period is that women are not having their children as early as they used to. So when I started reading medicine many years ago, this in the 70s, then the average age of a woman giving birth to her first child was 24. Today is 30. And I'm not talking about the Stockholm area or the bigger cities. That's all over Sweden, it's 30. So that is a dramatic change. And if you start when you're 30, of course, you can't have as many children as if you started when you're 18. And women do not breastfeed as long as they did previously. So sometimes when I asked if how is the best way of protecting myself from breast cancer, then I say, well, you should live like your grandmother or grandmother's mother, because she was certainly pregnant before the age of 20. She was constantly pregnant. Some of the kids survived. She was breastfeeding. There was no oral contraceptives, including hormones, and no hormone replacement therapy. So that's easy. But on the other hand, you can't go out and have come with suggestions of women should have their child when they are 20. That's violation of the integrity of women. So, but this is how it works on a population level. But
yes,
then,
I see.
But then sorry. Back to your alcohol question. It was long. I didn't even answer your question.
Yeah. So but you can get a second opportunity to do that now. So do you want to tell me and the listeners which is the largest impact risk factor that an individual can take control of, other than the high freedom reducing intervention of having children at an earlier age than one would otherwise want to? Are there any other
but we could again compare to cardiovascular disorders, myocardial infarction, and strokes, where you have risk factors that most people know: tobacco use, being obese, high cholesterol, high blood pressure, diabetes, physical inactivity. All these factors, definitely so, smoking and having high blood pressure, are extremely strong risk factors. And you could do something about it. You could you could measure your blood pressure, you could treat it, you could quit smoking, even though it's not simple. But you could definitely do something about it. When it comes to if you list the top 20 risk factors for breast cancer, the modifiable risk factors, except for those, having children early, as we talked about, they're on the bottom. They are like alcohol, tobacco, physical activity, obesity. But even if you don't smoke, you don't drink, you're physically active, you're not overweight, that will have a minute influence on your risk. So that's the challenge. Of course, we should encourage men and women to stay sober, don't drink, be physically active, not obese. And that is, of course, to the benefit of you, not only for breast cancer, but when it comes to breast cancer, again, it will have a very, very little impact. So therefore, when we started all this like 15 years ago, thinking about how we could identify women at increased risk and do something about it, we quite early understood that lifestyle changes will not influence the incidence or risk of breast cancer. Thus, we embarked on Tamoxifen studies.
Interesting.
Yeah.
So really, there's no habits or behavior that a woman wanting to care for themselves and prevent themselves from having breast cancers in the future that is actually effective and will have a large effect for them.
Yes, glad that you added large effects. So of course we should encourage people not to smoke and be careful about drinking and be physically active and don't be obese. And that will be to the benefit, from everything from cardiovascular disorders, cancers, knee problems, whatever. So that's but it will not have a dramatic influence on the risk of breast cancer. But you should of course be encouraged to do that anyway. So that's the problem. So I told you when I lecture, I have a list of risk factors and I rank them. You can see that they are really the bottom. But interesting also is that so when you look at density as a risk factor, so when we did the first analysis using the large cardinal cohort of the 70,000 women, we thought that after we had taken density and other mammographic features into consideration, we were so convinced that number of kids, age at first birth, breastfeeding, that will definitely add to our model. It turned out that it didn't, because it's already reflected in the density. So women who have many children, have been breastfeeding, started early, they have lower density than women who have not done that. So that's why our image-based AI-derived model is so simple. So let's see if I remember it. It's age, BMI, family history, hormone replacement therapy, alcohol, and tobacco.
Okay, so that was a separate model, and
so what we did though, yes. So we started off by we had 3 models. So the first paper was published 7-8 years ago. So 3 models. The first was completely image-based. Then we added on these factors that I told you about, and then on top, so that was model 2, and then model 3, we added on genetics. There was a slight increase in the ability of the model to pick that one will be diagnosed with cancer, that one will not be diagnosed with cancer, when we added the lifestyle factors to the images. adding genetics, there was such a tiny improvement. So the model, what we call the model 3, is not. There's so little benefit, so the cost will be quite horrendous. Also, maybe I should mention that in Sweden and in Europe we use mammography. There's 4 images, 2 breast tube views. In the US, they use something called tomosynthesis, which is sort of a computer CAT scan of a breast. So that's not 4 images; it's 200-300 images. If you apply our model to tomosynthesis, then you improve your risk stratification dramatically. So because there's so many images to choose from, it's so easy. If you don't identify any features that increase the risk of breast cancer, then you can safely say that if you don't identify anything among these 200-300 images, then there's nothing to be afraid of. So using tomosynthesis and applying our risk model, turns out that nearly a third of the women have such a low risk, so they will not benefit from screening.
Nearly a third of women. Can you explain that again?
So if you have a population of women who have been screened not using an ordinary 2D mammogram, but what they call a 3D mammogram, which is the same as a tomosynthesis, then you're able, with long follow-up, to identify a subgroup of women that has such a low risk, so they hardly develop any breast cancer.
Right, so they don't need screening, really.
No, they don't need screening. But this sounds like a simple message. They don't need screening, so we shouldn't invite them to screening for it. But I think that challenge is even bigger because, health-conscious women, they go for screening. And if you suddenly tell them that you have such a low risk, you don't have to come back. Yes, but could you be 100% sure that I'll never be diagnosed with cancer? No, I can't be 100% sure, but then I continue. So there are a couple of studies out there that says that women are not happy to be conveyed the risk, the fact that they have a high risk, but many of them are willing to go through supplemental screening. But women who are then given the assessment that you have a low risk, they're not always okay, but I would like to continue anyway.
I see. So women who have a high risk, they want to know that they do, but women who have a low risk don't oftentimes want to know that, or at least they want to be continued to
exactly. Yes.
So, yeah, I see. I want to end this episode off with, at least because we talked about risk factors that are controllable by the individual woman, and there seems to be really no one that has a large effect. But I still want to end this episode off with something that a woman can do to decrease their risk of getting breast cancer, or at least increase the risk or the probability that if they develop a breast cancer, that breast cancer will be detected at an early stage, so that the probability that it will be an aggressive breast cancer that cannot be treated will be lower. So can you please give us a prescription for how women can self-examine their breasts, and also comment on the importance of doing your screening as recommended?
Yeah, so first, if we start with screening, so when I lecture, which is a little bit embarrassing because I talk about changing screening, but I nearly always start by saying we have one of the world's best screening programs in Sweden, if not the best in the world. So we have a high attendance, we have super well-trained radiologists and nurses. So, and as a marker of that, there's 3% of the women are recalled and 0.5% are diagnosed with breast cancer, and it's recall rate of 3%. That's a marker of then you don't recall unnecessary. You don't biopsy women unnecessary. So that's fantastically it's one of the best screening programs. So women should definitely attend the screening program, because in the screened population, as I said, 70-75% of all cancers are diagnosed as stage 1, and they are cured. So the 10-year survival of a stage 1 cancer is 98%. So more or less all of them are survived. So that's the most important advice I could give. The second most important advice is, as you say, you should definitely, even if you go for screening, you should definitely examine yourself. So what then I encourage women to do is to log on to Cancerfonden, which have a really very good Cancerfonden Breast Cancer Förbundet, easily found on the net, have really good instructions of how to self-examine, and whether you do that in the shower or when you're lying down, or whatever you do it, but you should do it regularly, not too often, because if you do it too often, you will not detect a change. So once a month. Normally after you had, if you're a younger woman, normally after you had your menstruation, and then you do it in the shower or when you're lying in the bed. So that's because, even though I just said that we have the best screening program in the world, it's despite that the interval cancer rate. So in a screened population, 1/3 of the cancers are interval cancers, diagnosed between 2 screens. So and this is something that we hope a new screening program will change. So we will go from 1/3 to maybe 20% or something.
Yes.
It will not be possible to completely, even though there's some few smaller studies where the women are screened so meticulously, so there are virtually no interval cancers, which is quite amazing. Interval cancers, I don't think we mentioned that, they are normally very aggressive, fast growing, and these are the ones that kills women.
Yes. Can you go a bit deeper on the topic of how women can examine their own breasts? Like just a quick summary of the general principles?
Yeah, it's a bit difficult, but I've done this 1,000 times, many 1,000 times when I was working as a doctor at Department of Oncology at Karolinska. So normally what I tell women is I think they should do it when they are lying on their back. And then the way I do it when as a doctor, is that I divide the breast into 4 pieces, 4 slices, like pizza. Maybe you should pronounce it that I was described like that, but you know what I'm saying. And then what you use is this part of the hand. And you use the hand like this. So this part of the fingers, that's what you press the breast, you compress the breast towards the thoracic wall, because that's a hard under. You do like this, a circulating movement, and you are cautious in taking all the 4 slices. You start from the outskirt of the breast. That's no. Well, you go into the center, you move into the center. That's what you do, and you take all these 4, and not forget the area under the nipple as well. So that's what's going to be done. And if you use, some oil or whatever, it's probably easier. But that's definitely, so think about it, 4 pieces, use this part, press against the thoracic wall, and don't do it too often.
Right. I think that's an important point as well, because it can become an obsessive behavior, I think.
Exactly.
And cause a lot of anxiety if you do it every day, for example. So a balance. But once a month is appropriate, you think?
Yes, definitely once a month. And for women who are still menstruating after the menstruation, then the breasts are not as tender as before.
Right. Thank you for coming on the podcast, Per. I appreciate it.
Thank you very much. Thank you very much for having me.